first very important point is the time delay. So the 5 major studies that were gathered in Hermes meta-analysis showed that it's a very efficient technique in the first 6 hours. And then we were wondering whether we can extend the window to treat patients later, after 6 hours. And then 2 studies, Down, Diffuse 3, and now Aurora, have shown that there is a very low need to treat in this delay from 6 to 24 hours, meaning that the technique is even more efficient after 6 hours than before 6 hours. So now we know that in selected patients, thrombectomy can be done before 24 hours. The problem of it is with which imaging selection, and clearly as in Down and Diffuse, patients were over-selected with very strict imaging criteria and very small stroke volume, stroke core volume. So now the problem is that we know we can do thrombectomy from 6 to 24 hours. We don't know exactly on which imaging criteria, but it's absolutely clear that we should loosen those criteria and treat much more patients in this window from 6 to 24 hours. But we don't know exactly on which criteria. Is it aspect, core volume, etc. But there are probably much more patients that we can treat in this time delay. Probably the most important for me is the fact that the population doesn't know, even physician doesn't know, and cannot recognize the stroke, that the patient is doing a stroke, because the symptoms are very variable compared to a heart attack. And the fact that as well the healthcare system, the ambulance, the emergency physician, they don't know that we can do a thrombectomy. So cardiac stroke is considered extremely important emergency, when brain stroke is not considered as an emergency today, because a lot of people do not know that we can do thrombectomy. It was so fast. The technique is so efficient. In 3 years, all the RCTs have shown that the number needed to treat is extremely low. For example, the number needed to treat for brain attack is 2 to 7. For cardiac stroke, the number needed to treat is 50. So it's much more efficient than interventional cardiology. But this has been done so rapidly that now we have to explain that to everyone, the population, the administration of the healthcare system, and everyone. It's too new. You have to select patients. I mean, the point is that you have to have a clinical imaging mismatch. If you have a patient with a very severe stroke and a small core on imaging, whatever it is, it could be just the aspect score or a CT perfusion or a diffusion, then there is a mismatch between the clinical status of the patient and the small core. So in this situation, you know that there is brain to save, and then you should do it. We are wondering if you have a patient with an Alzheimer's disease or a mild cognitive impairment, then we don't know what to do, because we could consider the patient is not MRS1, he has some disability, so why treating? Should we treat the stroke? And it's really an ethical or philosophical discussion, and probably it's better for a patient to have the Alzheimer, but just the Alzheimer and not the Alzheimer plus a stroke. So even if it could be considered weird to do such an invasive treatment in a patient with already a very high disability, probably it's worth doing it, because it's better to have just the Alzheimer and not the Alzheimer plus the hemiplegia and the aphasia. That is a major problem of the brain stroke. Cardiac stroke, everyone knows that if a guy of 50 years old got a very acute chest pain, this is a cardiac stroke. Everyone knows it. Now in the cardiology field, for example, the societies of cardiologists are paying a lot of attention to the woman cardiac stroke, because the symptoms are much more variable. They are silent, or the variability is the symptoms are very different from the men cardiac stroke. And so there is a very important campaign of awareness done by the Society of Cardiology on this regard of the woman cardiac strokes. This is what we should do in the brain stroke today. The first point is that the symptoms of a brain stroke are very different. It can be a diplopia, some dizziness, some speech disturbances. There are a lot of different symptoms, and people don't realize that this is a brain stroke. So it's true for the population, it's true for some physicians as well. So I think that we have to have a campaign in Europe and in every country really explaining that all these symptoms can be or can reveal a brain stroke.
And that a brain stroke can be treated, because that's the other thing.
And that is exactly the other very important point, which is that people still don't know, even, it's 3 years ago that we have proven by evidence-based medicine that the technique works very well. There are still a lot of physicians working in the emergency department, a lot of them don't know that we can do stroke therapy by an endovascular treatment. So the awareness is still a major problem in our field. It's different in the US and in Europe. In Europe, we have the European Stroke Organization, who is very, very efficient. But it's new. It's just 3 years ago. So we have to be much more efficient in promoting what we are doing and explaining to the population and the healthcare system what we do, and to have a much better organization of the stroke care in our different countries. So one of the problems, for example, in France, is in France the system works quite well. And in my region, we have 3 million inhabitants, we do 300 strokes per year. But in my region, and it's true everywhere in France, 50% of the patients with a brain stroke never see a neurologist. So we lose 50% of the patients at the origin, because they don't know it's a brain stroke, they don't come and see a neurologist, and they don't come to us. Finally, it's a very rare situation today that the patient arrives too late to get a thrombectomy. The problem is that patients never arrive to the hospital because they don't realize they have a brain stroke. That is a very, very complex debate. The question is who should do that? And I'm a founding member of the European Board of Neurointervention. And the idea is to gather the neurologists, neurosurgeons, neuroradiologists, and to have guidelines about the training for trained interventional neuroradiologists, whatever their specialty of origin. And then guidelines as well concerning the number of cases that should be done in a center to validate, to accreditate this center. So the European Board of Neuroradiology works a lot with the European Stroke Organization, with the European Association of Neurological Surgeons and the ESMIN, the three societies together to write guidelines and to precisely determine what is the level of training people should have. We have to be much more visible for the population, the physician, the healthcare system. I think we should do it very rapidly. So we have more trained specialists, and our specialty, before we were treating only hemorrhagic diseases, aneurysm, AVM, dural fistula. Now we treat stroke as well. And it makes that our specialty is much more attractive for young people. So we have, 3 years ago, we were 3.5 in my team doing intervention, now we are 7. So in 3 years, we have been able to adapt, and the young generation are much more attracted by our specialty. The point is now is whether we should open many centers, for example, in France, and everywhere in Europe and in the world. And I think we should do it, but in very, very specific situations. Okay? The risk is like to do like maternity hospital. 30 years ago, it was considered that every woman should be able to deliver 50 kilometers away from his own home. And since 20 years, 70% of the maternity hospitals have closed. So we should not repeat the same scenario. I think there are regions that are far away from a big center in which maybe we should open a thrombectomy center. But it's in very specific conditions. This new thrombectomy center should be a satellite of a big comprehensive center, able to communicate by telemedicine 24/7 with the big center. And in France, we are discussing this, and we consider that we could open a center if this center is more than 150 kilometers or 1 hour and a half from the comprehensive center. And if this center has a huge activity in terms of stroke treatment and IV thrombolysis, at least 150 thrombolysis a year, meaning that this center will do 100 thrombectomy. It's not possible to open a center doing less than 100 thrombectomy a year, because then the level will be extremely low, and we are not sure that if the level is low, what has been shown in the randomized trial is true in the real life. So we spent a lot of time in Europe to discuss this point. Initially, we were considering that people should know everything, because if you do a stroke treatment and you end up with an hemorrhage, you should be able to handle this hemorrhage by coiling, gluing the artery. But then the problem is that you cannot have so many people doing everything. So we finally agreed to consider that we may train people, again, whatever they are, neurologists, neurosurgeons, radiologists, to do thrombectomy only. But these centers should be under the supervision of a comprehensive center.